Good afternoon, dear friends. Today we will discuss trauma of the spine. And as usual, before we'll start to talk about spine pathology, spine fractures, we'll try to remember basic anatomy and basic concept, basic main line for the better understanding of the supporting elements of the spine, for the better understanding main function of the vertebrae, facet joints, ligaments, and other supporting elements of the vertebral column. And I want to start from the most popular supporting elements concept at present time. I want to start from the Dennis 3 columns theory. And in that theory, we have, as you can see, we have 3 supporting columns: anterior, middle, and posterior. Right here on that slide, you can see anterior column. It is located right here, and anterior column represented by the anterior part of the vertebral bodies, anterior part of the intervertebral disc, and finally anterior longinal ligament. Then we have middle column, which is consists from posterior part of the bodies, posterior part of the intervertebral disc, and finally posterior longinal ligament. And posterior column, that's other anatomical parts of the vertebrae which are located to the back from the posterior longinal ligament, such as facet joint, which is located right here. Then we have intraspinatus ligament, supraspinatus ligament, one pair of the intertransversal ligaments, and ligamentum flavum, or yellow ligament, which is located in between the arcs of the vertebrae. If you will talk about the spine trauma, in general, most common location of the spine injuries, that's the cervical and lumbar parts of the spine. Thoracic part injuries are not so common because that is the most protected part of the spine. That is a part where we have ribs, where we have sternum. So those supporting elements prevent the common injuries of the vertebrae. And we will start from the cervical part. The cervical part, probably that is the most vulnerable to the injury part because of the high mobility, because of the one pair of unique vertebrae like axis and atlas. As you remember, the anatomy of those two vertebrae is different. For first cervical vertebra, we have 2 arcs and we doesn't have body. And for the second cervical vertebra, we have odontoid process, which have articulating surfaces for the connection with the first cervical vertebra. And because of those two vertebrae connection, we have a wide range of rotation, of the head rotation, plus we have a possibility to perform flexion and extension. So 7 cervical vertebrae have quite specific connections, wide range of the movement. That's why injuries of the cervical vertebrae are the most common. If you will try to understand which vertebra is the most commonly injured, you will see that the C5, C6, and C7 that is the most common location for the fractures. If you will take a look to the lumbar part of the spine, you will see that the most common location of the fractures are L1 and L2. So first two lumbar vertebrae. Why it's like that? As you remember, for the spine we have so-called lordosis and kyphosis. Lordosis, that is a curvature to the front, and we have lordosis in the cervical and lumbar part, and kyphosis, curvature to the back. And in the thoracic part we have kyphosis. So those two physiological curvatures are absolutely necessary for normal shock absorption. It's work like a spring. When we stand on the legs, when we jump, when we walk, that those curvatures, angles of those curvatures increase during the overloading, and when the loading reduced, the angle of the kyphosis and lordosis reduced. So those physiological curvatures work absolutely same way, if you talk about the physics, of course, as a spring. And as you understand, maximum loading during the axial compression we will have at the areas where the one curvature will be transformed to the other, where the lordosis will be changed to kyphosis, and opposite, where the kyphosis will be changed to lordosis. And as you understand, for cervical part area where the lordosis will be changed to the thoracic kyphosis, that's are the C5, C6, and C7 cervical vertebrae. That's why fractures at that area are the most common. And for lumbar part, absolutely the same principle. First two lumbar vertebrae, that is the area where the thoracic kyphosis change to the lumbar lordosis. The best we have what you should understand, we have present time we have quite many classifications which we can use for spine trauma, and in that lecture I choose the best one as for me, because in that classification we have combination of the X-ray findings and some clinical feature, clinical symptoms, and mechanism of the trauma. So everything is there in one classification, and that is a McAfee classification. So as you can see, you can use that classification for both cervical and lumbar part fractures. And in that classification, fracture number one, that is a wedge compression injury or wedge compression fracture, most common type of spine fracture. And for that injury, as you can see, the main cause, that is a anterior flexion or axial compression. Axial compression, example, falling from the height, falling from the second floor, third floor, and landing on the legs or buttocks area. For hyperflexion, example, probably most commonly it's happened during the car accident. So-called whiplash mechanism, when the driver have a belt and during the accident car very fast slow down the speed or stop immediately. At the same time, driver continue his movement to the front, and the belt, which is usually located around the chest, stops the movement of the chest. As soon as it's happened, for continue movement we will have only for the head, and that movement to the front lead to the forced flexion at the cervical part of the spine. That's why all modern cars have so-called airbags to prevent that hyperflexion. If there is no airbag, or airbag will not work properly. In that case, hyperflexion, the cervical part can lead to so-called wedge compression. So once again, mechanism, axial compression, usually falling from the high, or hyperflexion, whiplash, car accident, or another example, jump into the swimming pool when it's shallow. So in result, patient may achieve a head trauma, head injury, together with a compression mechanism to the cervical part. What we will see during the X-ray examination? During the X-ray examination, you will see that the anterior high of the vertebral body will be reduced. So if you compare posterior high and anterior one, you will see difference. So if you will return to the Dennis supporting columns concept, you will see that anterior column, in case of wedge compression, will be damaged. Anterior column, once again, that is anterior two-thirds of the vertebral body. Why it's like that? Dennis, when he tried to describe, or when he tried to split vertebral column for few areas, anterior, middle, and posterior, he split the different types of loading for different parts of the spine. He found out that the axial compression forces in general absorbed by the anterior part of the spine. Axial compression forces in general absorbed by the intervertebral disc and vertebral bodies. At the same time, distraction forces, which are not so common as the compression forces, in general absorbed by the facet joints and ligaments which are located to the back from the posterior longitudinal ligament. What does it mean? This means that if we knew the mechanism of the trauma, if we knew how it's happened, we can expect some type of injury. So if it's axial compression, probably your patient will have injury of the vertebral bodies and intervertebral disc. If it's distraction forces or extension forces, probably your patient will have fracture of the facet joint or arc of the vertebra. So wedge compression fracture, it is a classic example of the axial compression or forced flexion. Next injury, it is a so-called stable burst fracture. Mechanism is absolutely the same as for the previous one. It is axial compression or forced flexion, but the force for that type of injury should be much stronger. Usually it is high energy traumas. Once again, it can be car accident or falling from the height, but the floor should be higher compared to the previous wedge injury. So as you can see, main difference is the X-ray findings. On the X-ray you will see comminuted fracture of the vertebral body, and why we call it stable burst fracture, because for that injury the posterior supporting complex still intact. Facet joints, arcs of the vertebrae, intraspinatus, supraspinatus ligaments still intact. In general, main difference between stable injuries and unstable injuries of the spine is a condition of the anterior and posterior supporting complexes. If we have injury of the both anterior and posterior supporting elements, that means that we have unstable injury, unstable fracture. But if we have injury only anterior or only posterior supporting complexes by Dennis, in that case we are talking about stable spine fracture, stable spine injury. Type 3, it is unstable burst fracture. Mechanism is quite similar, is the same. is the same. It is a forced flexion or axial compression, but during the X-ray examination, you will find out not only vertebral body fracture, you will see together with that injury of the facet joints and injury of the intraspinatum ligament or posterior longinal ligament or ligamentum intertransversum. So it is a combination of anterior and posterior supporting complex injury. Another quite rare type of injury, type of fracture, it is so-called chance fracture. It is a condition when the line of the fracture passes through the whole vertebra. It is started from the anterior part of the body and goes along the vertebra until the spinous process. As you understand, it is example of unstable injury because all three supporting columns will be damaged. If you talk about the mechanism of trauma, usually it is a car accident. It is a situation when the car hit the patient from the side or from the back, and the force which is delivered by the car splits the vertebra for two parts. So once again, it is example of unstable fracture. Flexion distraction injuries not so common as wedge compression or burst fractures. For that fracture, as you understand from the name, we have combination of the flexion and distraction. In general, distraction, as I said before, it is not common mechanism. Very rare situation when the distraction can be applied to the spine. But if it's happened, as you understand, initial injury should be located at the area of facet joint and intraspinatus ligament. If the force still applied on the vertebra after the posterior column injury, we will have involvement of the anterior column. It can be injury of the intervertebral disc, as you can see here on the picture, or it can be fracture of the vertebral body. Of course, as you understand, it is example of unstable injuries. Once again, all three columns will be damaged. Translational injuries, once again, the name of trauma itself explain or show us that some of the vertebra, some part of the vertebral column should be translated, should be displaced somewhere. Once again, it is example of unstable trauma, and once again, it is usually happened during the car accident. So as you understand, the force should be quite severe, quite strong to lead to the complete fracture of the vertebral body, arc of the vertebra, and facet joint at the same time. If we will talk about cervical part injuries, except the McAfee classification, we should use quite special classification for first and second cervical vertebrae. Here on that slide, you can see C1, you can see atlas. Once again, as I said before, anatomy of that vertebra is quite unique. We have lateral mass here on the both lateral sides, and that is the most massive, most stronger part of the vertebra, which is responsible for the connection with the head, with the occipital ball. Here you can see articulating surfaces for that connection. Then we have two arcs. We have two arcs, anterior and posterior one, and we have two foramens, lateral foramens, which are absolutely necessary for vertebral arteries. As you remember, two vertebral arteries pass through the cervical vertebrae exactly through the transverse foramens. So how we can classify the fractures of that vertebra? For that reason, we can use Jefferson classification. And the name of the fracture actually is Jefferson fracture. So we have a few types of Jefferson fracture. For type 1 or type A, it is simple isolated fracture of the arc, of the anterior arc. Type B, it is fracture of the anterior and posterior arcs at the same time. And type C, it is unstable injury of the C1. It is a fracture of the anterior arc, posterior arc, and transverse ligament at the same time. As you remember, the transverse ligament is very important for odontoid process fixation, for the dance fixation. And as soon as we will have type 3, type C, Jefferson fracture, we will lose connection in between C1 and C2. And as you understand, in that case, we may achieve displacement of the odontoid process, and as a result, compression of the spinal cord with that odontoid process. If it will happen, as you remember, it is very important part of the spinal cord when we have respiratory and cardiovascular centers. So compression of that part may lead to the immediate death of the patient. So Jefferson. Another type of fracture, it is a fracture of the C2, second cervical vertebra, which we call Hansman fracture. Quite interesting name, why Hansman fracture? If you remember ancient history, we have so-called ancient Rome method of the hanging. And the main idea that the knot, if you talk about the hanging process, about the rope, knot was located at the lateral part of neck. So what does it mean? That means that the reason of death, if the knot located on the lateral side, on the lateral part, it was asphyxia. So people from UK, they try to change that situation because asphyxia itself, it's not very good picture, because during asphyxia you can see changes of the skin color, it's become bluish, dark. You can see urination, defecation during that process. The eyes came out from the orbits and so on. So people from the UK, they try to change that situation, and they shift the knot from the lateral side to the front. So as soon as the patients lose support below the legs, those people had hyperextension, not press on the mandibular, not press on the head, and those people had intensive hyperextension. So that intensive hyperextension may lead to the fracture of the odontoid process. And if it will happen, as we discussed before, that odontoid process may displace and compress the spinal cord at that level. And if it will happen, patient will die very fast. So the reason of the death will be not asphyxia, but the failure of the cardiovascular or respiratory system, once again. So that's why the name of the fracture is Hansman fracture, because it may happen during the hanging, if the knot once again located at the anterior part of the neck. Another classification, which is very useful as for me, it is so-called Anderson de Alonso classification. It is a classification of the odontoid process fractures, where we have three types of injuries. Type 1, it is a partial fracture of the odontoid process, as you can see here on that picture. Type 2, it is a complete fracture of the odontoid process. And type 3, it is a fracture of the odontoid process together with the part of the body. So the most dangerous type, of course, it is the type number 2, because in that case the bone fragment is quite big for possible future complications. So it is big enough to lead to the severe compression of the spinal cord. In case of type 3, bone fragment is big enough as well, but usually we have stuck, so-called stuck fractures, so odontoid process becomes stuck together with the body, and we usually in that case we doesn't have severe displacement of the bone fragment. If it doesn't have severe displacement, we will not achieve compression of the spinal cord. So clinical evaluation, да? I would like to split clinical evaluation for two parts. The first one, it is clinical symptoms and medical help, which we should provide at the street, at the place of accident, so-called first medical help. And the second part, it is qualified medical help which should be provided in the hospital. So, of course, initially, before you will start to do something, you should find out the diagnosis. You should try to find out what happened with your patient. And for that reason, of course, we use absolutely the same principles of the traumatologic patient's examination, which include inspection, palpation, if it is necessary, auscultation, and if your patient is consciousness, complaints, of course. So if you provide medical help on the street, you doesn't have approach to the X-ray methods, you doesn't have approach for MRI, you doesn't have approach in general for any instrumental methods of examination. In that case, you can use only your eyes, hands, and you can ask your patient some questions. Of course, first symptom of the trauma, it is pain. Any alteration or any injury will lead to pain. It can be minor pain in result of inflammation, or it can be more severe pain which may happen in result of nerve endings irritation. For example, in case of fracture, we will always have irritation of the periosteum, and as you remember, periosteum have a perfect blood supply and innervation. So of course it will be very, very painful. So pain at the cervical or thoracic or lumbar part, it can be a symptom of the fracture. Then disturbance of the movement. As you remember, we have active and passive movement. So if your patient can't turn his head to the side, or if your patient can't perform flexion or extension of the cervical part of the neck, it is another symptom of the possible serious injury of the fracture. Another symptom, it can be neurological symptoms of the neurological disorders. It can be numbness in the hand if it's a cervical part, or it can be numbness in the leg, quite common for lumbar part injuries, or it can be a symptom of the spinal cord traumas, complete paraplegia, for example, or complete numbness which patient may feel in the hands or legs. If you expect fracture of the spine, of course, first what you should do, it is immobilization. How to immobilize the cervical part of the spine? Of course, for that reason, we use special collar cuffs. By after, we call it Schanz collar cuff. For lumbar and thoracic part, we should use special stretchers, or we should use some hard surfaces. It can be door, it can be some desk, whatever you can find at the area near the area of the accident. But most important thing, it should be flat and hard surface. Next thing, how many persons can shift the patient from the accident place to their to the desk, for example, or to the crashers. Not less than 3. Not less than 3. If you doesn't have 3 assistants, in that case you can't shift your patient, because the key of the shifting is absolutely simultaneously transferring of the shoulders, pelvic, and legs. You should avoid any movement at the area of the spine, because if it's unstable injury with during your movement, during the shifting of the patient, you may lead to you can do some future complications or future injuries of the internal organs or spinal cord. So as soon as you immobilize the spine, once again, it can be collar cuff for the cervical part or hard surface for the thoracic and lumbar part, you should transport your patient to the hospital. In the hospital, you can prove your initial diagnosis, with the instrumental methods of examination, with the CT scan, MRI. If it is necessary, you can use some other methods of examination. Of course, neurological examination is absolutely necessary. As you can see on that slide, you can check superficial sensation, pain, you can check tactile sensation, you can check temperature sensation. After that, you can perform rectal examination to find out perineal sensation, or you can check bulbocavernosus reflex to determine has the patient the spinal shock, or maybe a patient have a permanent complete lesion of the spinal cord. Then CT scan imaging, MRI. You should remember that the CT scan imaging will give you better information, better picture of the vertebrae, of the bones, and MRI opposite will give you better information about the spinal cord condition, about the nerve, spinal roots, spinal nerves condition, or brain if it is necessary. So depends from your task, depends from your ideas, you should prescribe CT scan or MRI. And as soon as the final diagnosis will be proved, you should prescribe treatment. Almost 50% of the patients who sustain spinal trauma have other associated injuries. So, as we said before, falling from the height or car accident quite commonly lead not only to the spine trauma, as you understand, but together with that, your patient may have injuries of the kidneys, head trauma. Patients may have injuries of the intestine, injuries of the spleen, and lungs or heart. So actually, in most cases, together with the spine trauma, we will see some other associated injuries. Patient management begins at the accident site. We already discussed that, how it begins and what we should do. The most common spine injuries occurs as a result of motor vehicle accident. As I said before, in most cases, spine injury is a result of high energy trauma. Then, timing of surgery. No, let's say that not always it is necessary to perform surgical treatment. For simple wedge compression fractures, wedge compression fractures can be split for a few types as well. We have grade 1 wedge compression fracture, grade 2 and grade 3. Grade 1 wedge fracture compression, it is a condition when the anterior high of the vertebral body reduced less than on 1/3 compared to the posterior high. Grade 2 from 1/3 till 1/2. And grade 3, it is a compression of the anterior high more than on 1/2 compared to the posterior high. So, if you talk about the type 1 or grade 1 and grade 2 fractures, compression fractures of the vertebrae, it is absolutely possible to use a conservative management, to use a conservative treatment. What we should do? You should just keep your patient in the bed, so we prescribe straight bed regime during few days, usually few weeks, 2, sometimes 3 weeks after the trauma, patient should stay in the bed. If the patient stand up, you should use special supporting orthoses, special supporting fixator belts, which will reduce loading to the damaged vertebra. So our main idea, our main task during the conservative treatment prevents the future compression of the damaged vertebral body. Just try to save it at the initial high and achieve healing, achieve consolidation of the vertebra during 2-3 weeks after the trauma. If your patient have injury of the thoracic part, wedge compression of the thoracic part, especially if it is a situation when we have a few vertebral bodies compression, in that case, sometimes it is necessary to perform reclination procedure. It is necessary to restore the angle of kyphosis. As you remember, at the thoracic part, we already have kyphosis. And if you have 2 or 3 vertebrae wedge fractures, the angle of the kyphosis becomes very severe. And in result, your patient may have so-called hunch formation. So to avoid that situation, you should try to restore the high of the anterior high of the vertebral bodies. How to do it? You can use special beds, or you can use even ordinary bed with a hard surface, but you can put the small pillows under the curvature, under the wedge compression vertebra. And day after day, you can change the size of that pillow, of that bag. So the main idea is that you will try to reduce the angle of the kyphosis. And if you will do it, the anterior high of the vertebral body will be increased as well. So reclination procedure or just straight bed regime. It depends from situation. It depends from the clinical case. If your patient have, let's say, when we should perform surgical treatment, or other way, what are the indications for surgical treatment? First indication, that is complicated spine fractures, complicated spine injuries. It is a condition when the patient have, together with the fracture, have injury of the spinal cord or internal organs. Or Second indication, it is so-called unstable fractures of the spine. Once again, unstable fracture of the spine, it is a condition when your patient have injury of the anterior and posterior column at the same time. So, if your patient have neurological complications, it can be complete spinal cord injuries or incomplete spinal cord injuries. In both cases, we should use surgical treatment. But some authors recommend to delay the time of surgery for several days to reduce spinal cord edema. For neurologically normal patients, for the patients which doesn't have neurological complications but they have unstable injuries, we should use surgical treatment as soon as possible to avoid any displacement, because as you understand, any displacement in that situation may lead to neurological complications. And the main idea, the main task of the surgery will be fixation and stabilization of the spine. In general, all surgical procedures in case of spine trauma can be split for two big groups. First one, it is decompression procedures or decompression surgeries, and the second one, it is stabilization surgeries. Sometimes we perform both decompression and stabilization. If we'll talk about the surgical approaches, for the cervical part of the spine, in most cases, we use anterior approach. For the thoracic and lumbar, in most cases, we use posterior approach. Why it's like that? Because anatomy of those areas showed us which approach better to use. The surgeon always try to use approach which will be safer, where he will see as less important anatomical structures as it can be. So if it will be posterior approach for thoracic part or for lumbar part, you will not need any big blood vessels or some big nerves which you can damage during that approach. No, instead of spinal cord and spinal nerves itself. For the cervical part, posterior approach is not dangerous as well, but fixation of the vertebrae will be more simple if you will use anterior approach. I will explain why a little bit later. Before any surgery, it is very important to perform proper planning of the surgery. Without CT scan imaging, without X-ray examination or MRI sometimes, it is absolutely impossible to perform good planning of the surgery. So, good examination of the patient is vital for the successful surgical treatment. Laminectomy at present time has a limited role in the treatment of the cervical fractures or dislocation and may contribute clinical instability or neurological deficit. If you will take a look to the surgical procedures which was performed 15 or 20 years before, you will see that the main surgical procedure which was done, that is a laminectomy or gemilaminectomy. That means that the doctor removes the half of the arc or completely removes the lamina of the vertebra to achieve good decompression. But with the time, with the experience, doctors understand that it is quite serious injury of the posterior, once again, supporting elements, which may lead to the future instability of the vertebrae. And we even have a term like post-laminectomy syndrome, It is a condition when the patients after the laminectomy achieve quite serious neurological problems in result of vertebral body's displacement at the area of surgical procedure. So at present time, surgeons try to avoid serious injury of the supporting elements of the spine, if it's possible, of course. Compression of the cervical cord or roots by retropulsed bone fragments or disc material usually is anterior. Therefore, anterior decompression, fusion with or without internal fixation are indicated. No, it is clear, I think. For the posterior ligamentous or bone instability, posterior stabilization with the internal fixation and bone grafting are indicated. Let me show you a few clinical examples. What approach, where I will explain you what approach we usually use, what surgical technique we usually use, and the most important, you will see how it looks like during X-ray or CT scan or MRI examination. So the first example, it is a burst fracture of L2 in 42 years old woman with incomplete paraparesis 3 weeks after the trauma. So on milligrams, you can milligrams, if you forget, it is a method when we inject contrast solution into their subdural cavity. So we inject it into their cerebrospinal fluid, and in result, the cerebrospinal fluid become visible. And after that, we can see the level of compression, where the spinal cord become compressed. We can understand how severe is the compression, and we can plan the surgical procedure after that. So as you can see on the picture, myelographic pictures, we have extradural compression of L2 at the level of L2 from retropulsed area. So here on the CT scan imaging, you can see that the bone, that is the burst fracture of L2. If you try to remember McAfee classification, which we discussed before, you will see a few bone fragments, actually first one, second one, third one, fourth one, so at least 4 bone fragments at the area of vertebral body. And you can see some bone fragments, a retropulsed fragment which is displaced backward and compresses the spinal cord or cauda equina at that level. So here you can see that fragment as well. That is a vertebral canal, and here you can see a huge fragment which is located inside that canal. So our first task was to perform decompression. Our first task was to take out that displaced bone fragment from the canal. And after that, we should fix other smaller fragments at exactly at the area where we should have vertebral bodies. For that reason, we use grafting procedure. We take the part of the iliac crest from one side and perform transplantation of that iliac crest into the vertebral canal. So we form the posterior wall of the vertebral body with that grafting material. Here you can see how we put it in between two nearest vertebrae, between L1 and L3, and how that wall prevents the future displacement of the bone fragments into the canal. Another example is compressive flexion injury in 20 years old woman with a complete C5 quadriplegia. Remember, C5, C6, C7 most common location for the fractures, for the cervical part fractures. So once again, you can see damaged vertebra on the lateral plane X-ray, and here on the CT scan you can see that the vertebral body completely split from the arc facet joints. So actually we have complete splitting of the anterior and middle column from the posterior one. So our main task in that case was fixation stabilization of anterior, middle and posterior column. For that reason we use grafting. Once again we take the spongy bone from the pelvic area and perform transplantation to the damaged vertebral body area. And after that, as you understand, we achieve fusion in between the damaged vertebra and two vertebrae above and below. So it is example of the surgical procedure which we call spondylodesis of C4, C5 and C6. Spondylodesis by autografting. Another example, actually, the same patient CT scan imaging, you see that the vertebral body not only split it from the arc, it is damaged as well. You see that the vertebral body split it for two halves. And post-operative picture, you can see it right here. It is a spondylodesis in between three vertebrae. Another method of spondylodesis, it is plating, so-called plating. So for vertebrae fixation, we use special implant. We call it cervical plate, which we apply on the anterior surfaces of the bodies. And after that, we fix that plate with the screws. And as we understand, that plate prevents any movement and any displacement in between those vertebrae. And on that example, I can try to explain why it is better to use anterior approach for the cervical part of the spine. If you will use posterior approach for that case, you can perform a spondylodesis with a transpedicular screws fixation. You can see it right here actually. But it is quite dangerous procedure. Why? Because what does it mean, transpedicular screws? Transpedicular screws, that means that you should put your screw through the pedicles of the vertebrae inside the vertebral body. And take a look the line, how the screw should pass through the pedicles. That is the point of insert, and that is the end point where the tip of the screw should be located. So it should go like this, and same way on opposite side. But you probably understand that if you will choose improper angle, if you will put it too laterally, you will damage the vertebral artery, which is located right here. And the same story if you will put it too middle. If you will put the screw too middle, you can damage the spinal nerve, which is located right here at the lateral part of the vertebral canal. And then that nerve came out, go to the lateral side and came out from the vertebral canal through the intervertebral foramen. So that means that position of your screw should be absolutely clear and very, very checked. So if you doesn't have any chances for mistakes. At the same time, if you will use anterior approach and if you will put plate, you doesn't have any chances to damage the spinal nerve or some big artery, because at the anterior surface of the cervical vertebrae, we doesn't have any spinal nerves or any vertebral arteries. So approach by itself, as I told you before, is much easier, and the procedure is much easier. Another example which I want to show you, it is a complete displacement of the vertebrae in result of trauma. Here on the MRI it is very clear. You can see as the vertebra completely displaced to the front, first, second, third, fourth, fifth, no, again, six cervical vertebra displaced to the front, and in result, the seventh cervical vertebra completely compressed the spinal cord. You can see what happened with the spinal cord. So it is almost ptosis, Ptosis, it is a condition when the vertebrae above just go down to the along the distal vertebra, and you understand what will happen with the spinal cord in that situation. So in that situation, what you can do? In that situation, you can try to restore the normal alignment between the vertebral bodies, and once again, you should try to perform a spondylodesis with a plate and screws. But the problem is next, as you understand, if you have complete injury of the spinal cord at the C6, C7 level, it will lead to quadriplegia, and that patient probably will not restore the function of his hands and legs. What about the treatment of C1 and C2 fractures? On that picture, you can see how the surgical treatment for adontoid process fractures provided. Approach usually through the mouth. First, what the doctor do, he puts wires inside the C2 vertebra, along the body, inside the adontoid process, and then through those wires, doctor put special cannulated screws inside. Cannulated, this means that we have a hole inside the screw, and if the wire is already located at the necessary place, you doesn't have any chances to miss that location. You doesn't have any chances that your screw will go to the improper direction, will take improper position. So, as you understand, we need the X-ray machine and the operating center to put initial wires inside the adontoid process. But as soon as you put wire, it is absolutely not difficult procedure to put inside that vertebra the special cannulated screws. Okay. Few words about the possible complications. So the first one, as you can see, it is respiratory failure and infections. Second one, it is urinary tract infections, quite common in case of intermittent catheterization program, or in general, if a patient have prolonged catheterization of the urinary bladder. Bad sorders formation, if your patient have some neurological disorders which are prevent his activity, at least in the bed. Increasing of the body temperature, adequate increasing of the body temperature, no, that's it. Probably, colleagues, that's all what I want to tell you about the spine fractures. And during the next lecture, we will talk about the pelvic injuries, about the pelvic fractures. Okay, that's it. Good luck and goodbye.